Hello, everyone, and welcome. My name is Meena Dayak. I'm the Executive Vice President, Market Intelligence at Open Minds. I will not be talking to you about revenue maximization today. I am just your moderator for the web briefing. As we all try to navigate the new normal that COVID-19 has created, we at Open Minds are here to help specialty health and human service provider organizations with our new program called the Executive Blueprint for Crisis Management. And through this program, we are providing on-demand resources and technical assistance, not only to help you manage through this crisis, but also to help you start planning for what comes after for recovery and resilience. And so today, my colleague and Open Minds Senior Associate, Ray Wolfe, will walk you through strategies for revenue maximization during times of disruption, building top line to sustain margins. Let me tell you a little bit about our presenter today. So Raymond Wolfe, JD, brings over 40 years of experience in the health and human service sector to the Open Minds team. He is currently a senior associate, which means he uses his expertise to successfully lead a variety of projects for Open Minds clients. And his areas of expertise include managed care and value-based reimbursement models, financial analysis and management, mergers and acquisitions, CCBHC certification, integrated care, performance improvement, and strategic planning. And that's an impressive list, and I am really thrilled that Ray is here to share his expertise with all of you today, and thank you for making the time to join. Just a couple of housekeeping reminders before I hand it over to Ray. You are muted throughout today's briefing, but we welcome your questions and comments. Just type them into the chat box on the right of your screen and send them in to us. We'll save your questions and Ray will address them at the end of the presentation. And after the presentation, you can also send in more questions at that time. And I know that one thing people always want to know right from the get-go is, are these slides going to be available to us? Will we have a recording of today's session? The answer is yes. You will get an email with a link to the recording and the slides, and we will also post them on the Open Minds website by tomorrow, and you should be able to access them. So looking forward to the next hour of wisdom from Ray. Over to you, Ray.
Thank you, Meena. I appreciate it very much. This issue of revenue maximization that we want to talk about today, I think is very heavily overlooked in our market, in our industry. We grew up, the DNA of our finance departments was based on expense control. Our payments were either grants or cost-based allocations from government. So as long as we maintained control of our expenses, we did okay. Even when we moved into areas such as Medicaid fee-for-service, the rates were so low that expense control remained a big issue in terms of the way we dealt with our company. If you flip that and look at the for-profit sector and look at businesses operating in that regard, revenue maximization is a huge chunk of what they do. It is probably 50 to 60% of the effort of the finance department in finding ways to increase and grow their strength. This becomes a critical link for us as we face what I've been referring to as the urgency of now. And we just got some statistics on that are not very good. This is a survey provided by National Council, which shows that 38.5 billion will be lost in revenue this year by mental health and addiction treatment providers. The number of providers who are closing programs is massive, 60% nationwide, with some states reaching as high as 85%. And we're already beginning to see providers close their doors. Arizona, Michigan, New Jersey, Pennsylvania. Many of the providers are telling the National Council, more than 60%, that without emergency financial assistance, they may need to shut their doors within 90 days. That number grows in certain key states. South Carolina, it's over 80. The state of Florida is in a complete emergency. While we have to do everything that we can in terms of managing expense, we have to also look at new skill sets that we should add to our repertoire to create the kind of atmosphere that we can survive and grow in. I believe the organization of the future, the provider that will survive from this and grow and thrive into the future, will also be very, very closely focused on cash flow management and on revenue maximization. And because of that, I'm very happy to have been assigned the effort of researching and providing information on both those topics. With respect to the revenue maximization process, there are a few steps that I'd like to simply walk through with you at a very high level in order to begin to explore these things more in depth. If I could touch on something that you want to ask a question about, feel free. If in fact the question arises after this is over, I will have my email at the end, and feel free to contact me concerning this effort. However, I want to walk through, I think, about 5 different items today and hopefully provide at least enough of an overview that you can determine what impact or how valuable it might be in your provider organization. First, I'd like to look at what it takes to maximize billing. All of those internal systems that will affect the way that revenue is collected. We have to, before we begin to look at other ways of doing business and other ways of maximizing reimbursement, we have to first look to make sure that we are not leaving money on the table. So for many of you, this area may be one that you have worked with before and understand fully, but frankly, it is one that we need to begin and to develop a baseline for the entire industry. Secondly is, how do we increase intake? For fee-for-service, we understand that one very big key is volume, productivity, the number of widgets produced on any given day. And I think that crisis referral programs provide us an opportunity to change the revenue matrix that we have in our entity in unique and different ways. Finally, thirdly, there's the issue of increasing rates. What's it take to negotiate? How do you find leverage and win-win situations when you're dealing with insurers, MCOs, governmental entities? Fourth and fifth, I want to look at other elements that might play into this mix. First, value-based reimbursement is coming, is here in many places, and will grow. I believe very strongly that what you're going to see as we face this new world where government spending is going to have to be curtailed over present levels is that there will be an enormous shift to try to find the most productive, the most efficient, the most effective providers in our industry and to work with them. So we should be working today, even in the midst of this crisis, to build the kind of revenue we will need in the future. Finally, I just want to add my own thoughts about a couple elements that I think are very important. One being managing your internal portfolio correctly so that you have the right programs yielding the right results. And finally, and also that you are leveraging any opportunities to increase your size or increase your negotiating capabilities in this new environment. So with that background, let's start looking at maximizing billing. Revenue cycle is a system. It's a standardized machine that builds items from point 1 to point 5 and completes it. When you think of it as a system, you have to understand that it is best run when it is run standardized, when all of the activities for everyone in that flow actually are performed in a habit format. But that's not the way it generally works, because even though we have standardized pieces for data gathering, for pre-verifying the data we've gathered and make sure it's correct, that we've looked at service delivery and made sure that notes and the actual paper requirements for authenticating a service are done. And we can move then to initial screening of those bills and final payment. But as we move through all 5 of those, we have to remember that we represent in that matrix a number of different departments. Perhaps the initial bill screening and the processing and collections all occur in AR, but service delivery is a clinical function, and data gathering is the function of administrative clerks, often who don't report through the AR system. Pre-verification may be done by someone entirely different. And in the mix of all this, we can add staff from the medical records department. So we're looking at multiple different departments with multiple different demands, operating differently than the system may expect, and doing so even differently between sites. So the system becomes much more complex and frankly much less automated than we might think. The key to addressing this and creating the kind of revenue cycle that we need lies very clearly in the ability to do continuous quality improvement and to do it according to the traditional forms and functions that Lean or Six Sigma provide for us. There should be a focus in assuring that everyone at every site, in every department, has an understanding of this. Administration needs to bring focus to this effort, to let people know that this is something being watched and will be done and improved. The staff involved have to develop a team structure, a level of communication, a common set of goals and trust. There has to be some way to perform nimble reaction, because denial forms will suddenly appear overnight from different payers. Changes will occur in the way an insurance card works. Things happen on the fly, and we have to be able to respond to it. Finally, we have to maximize the value of staff effort. We're looking at 4, 5, 6, at the maximum sometimes, AR clerks who are required to bill and to collect perhaps 30, 40, 50, 60, even more $1 million in revenue. They have to dedicate their time and effort to the places that are most likely to yield results. To me, this has always meant that rather than chase the front-end employee or the front-end client who, the self-pay client who may not have more than $10 or $15 in cash or spend time setting up those kind of key payment plans, it's better to take that person and dedicate them to your largest payer. Build relationships, find out what they can do to increase the payment speed or payment accuracy, and to begin to focus, like Bonnie and Clyde told us, where the money is, and to focus on those kinds of efforts. There are 3 ways in which we need to develop goals for our AR cycle. The first is accuracy of collection. We need to be sure that every bill and every claim that leaves the system is as clear as possible, is as clean and transparent as possible. When I look at this process, what I tend to see is that there is a KPI that we should be monitoring, in that these quality improvement teams should review around percentage of denials. How many claims are in fact denied? By what payer? For what reason? It provides us the data we need to begin to attack the biggest problems, the biggest dollar amounts of denial, and move that correctly. When you set a benchmark for looking at those denials, you want to start with the idea of where am I right now? What can I do if I improve 5% or 10%, and to get that into the process. But in eventuality, every payer should be producing at least 95% on a regular basis of what we bill. And 95 to 100% is the only really acceptable range for these folks. Now, I'm excluding patient responsibility from that mix, but in regards to data errors, denials, changes, those are the kinds of things you will see. Common issues in this area missing data, incorrect data, inconsistent data entry where a number was entered one way in one site and another in a different site or a different function, and exceeding maximum permissible services. As these issues develop, or as you begin to see these or others, the quality improvement team, again, should be focusing on the biggest impact they can make by addressing the denials that create the largest amount of error and problem. The second element that I think is problematic here is the speed of collection. Just a few days delay in payment from a major provider can create untold amounts of problems during a pandemic like this or a serious crisis that we face. Days in receivable by payer become a key metric to watch, and we need to find ways to reduce it. Again, historical averages are important, but if all billings are electronic, the total should approach 30 to 40 and no more than 40 days. In that regard, we ought to be seeing as fast a turnaround as possible. I understand that when we deal with state governments and we deal with Medicaid, we are dealing with folks who don't know the meaning of speed in many cases. But nonetheless, those kind of mixes should occur. Traditional problems in this area, and maybe some of you have exceeded it, are batch billing, excessive denials that for any particular reason, internal information delays in getting bills put together, and finally, failure to press the payer. If in fact you are seeing paying on clean claims, those that arrive very quickly at the payer's desk and have no problems, if you're seeing clean claims that are taking longer than 35 days or 40 days to process, then you might want to visit that payer and talk about it. I believe that there's no reason, having lived with a Medicaid managed care organization in Pennsylvania for many years that had a standard of paying in 28 days or less for clean claims, I don't think there's any reason for people to exceed that. What we saw, what I think some people might see, are payers that we do less volume with who frankly are, well, they ignore us a bit. They focus on the hospital claims and the big insurance claims that they have, and maybe ours don't get the attention they deserve. Something as simple as a visit to that payer or a telephone contact with someone in the executive process to explain that other commercial payers are paying you at a rate that is much better for clean claims that move through the system is, I think, an effort towards dealing with these issues and moving us in the correct direction. Finally, there is the issue of follow-through. When I look at AR graphs, they tend to look like dragons. It would be very high at the front end if you're looking for claims 0 to 30 days old. That's where all the claims are and none have been paid. Somewhere between 30 and 60, you'll see this big drop off, and the graph will drop dramatically as claims are paid, and it'll drop even more and finally level out at somewhere about 4 or 5%. And then at the end of the graph, there'll be this category called over 120 or over 180 or whatever your standard is, and there'll suddenly be a very large amount of bills in that area. These are bills that just haven't been worked correctly, or bills that we really don't have any basis to believe should be paid. When they gather like that, they create problems for AR clerks in managing this process. And we need to make decisions about whether we should write those bills off, whether we should move to a different area in that process, how do we manage it. If we can't staff correctly because of our own size or financial issues to assure that follow through is met, there are AR factoring agencies now that can buy your AR of a certain age and process it and return what is not done. So you can frankly purchase tail end coverage for AR that allows you to do the follow through that might be missing because your AR staff is so busy correcting data to make sure the first bills are paid, verifying information because people move back and forth between insurance plans so quickly, and that they may not have caught or attained this kind of collection. To do these correctly, there are a lot of software products, but if you built something even in Excel that gathered the KPI and established these benchmarks and did so by payer, I think it would be helpful in providing information to what I think is this essential revenue maximization quality improvement committee that you need to build within your system. What I haven't discussed during the course of this is the coding conversion. What are we losing as a result of poor coding? Unfortunately, many of us don't have IT systems which automate that process. Some of them go a good direction with that regard by limiting the kinds of codes that certain providers can bill so that you're assured that people are credentialed correctly for the codes they're billing. But in that regard, you need to ask several questions, and there needs to be continual dialogue between your medical records department and your clinical staff around, is this the right code? For me, the issue was always, is it the right duration? Have we billed correctly or have we underbilled for an event that really went on longer? Are your staff truly marking in the times to the minute that they're performing certain functions? Or are they just roughing it out and in the process probably losing money? All good AR systems right now should have a process of correcting issues to make sure that codes go to the correct payer and are billed appropriately. That is a highly complex system based on very unique algorithms for each payer. And frankly, someone in the AR department, probably an AR director, should be responsible for maintaining those tables and assuring they're correct. But in the absence of that, just getting an automated bill correctly at the maximum value to the person for payment becomes difficult. Are providers trained? Do they know what they're doing in terms of process flow? Do they understand the impacts of their decision about timing or the codes they choose? And frankly, as we look at these third generation billing systems that are out there, many of which are not only fully ready for fee for service, but are also really prepared to gather and integrate the data that we need for value-based reimbursement. Are these decisions fully automated? Is our computer system doing everything it can so that my minimal staff in administrative clerking and medical records and accounts receivable can really get the maximum effort for the time they spend in terms of this payment? Unfortunately, talking about expenses at this point is not something anyone wants to hear, but if there is a medical record change in your future to a newer, fresher, cleaner version, I would not delay it at all. These things are not just effective projects that yield a return on investment. These are essential. These are mandatory tools to live in the future. So let's talk a bit about crisis. And why am I talking about crisis in the first place? Frankly, when I look at the crisis unit, what I'm seeing is that it is a unique opportunity for us in new ways. The simple math that we look at in fee-for-service is the number of units times the rate that we get paid per unit, and that equals total revenue. And the problem we are facing today is the number of units we are receiving. That has changed radically. So the total revenue is off because of productivity. On the flip side of this equation, when you look at expenses, many of our expenses are fixed. The number of staff that we hire. The cost of a building doesn't change whether we have one person or 50 persons in it. those sorts of things mean that as units drop, expenses will not. They will stay largely the same and drop only by a much smaller percentage of the whole. So if we can't control the number of units in terms of productivity, we can't beat this problem. And that's why crisis. Crisis is a program that is needed everywhere in every structure and place. It unites us and creates opportunities for us that address high cost, high service clientele. For those clientele, it is very clearly a way for us to both beat the rate, productivity, fee-for-service formula that we're facing today, but also to be ready for that value-based reimbursement activity tomorrow. High cost, high service clientele are folks that insurers are very, very frightened of. And in that regard, what we're going to see is those are having contact with and engagement with that clientele are things that insurers are going to look for. The referrals that flow from a good crisis program are exceptional because they create internal linkages to case management. And the case management then can work with other long-term programming and service programming in our areas. A person who arrives as a high-cost, high-service clientele in crisis may be assigned to 3 or 4 different kinds of programming within the company. Simply bringing in one person may expand your productivity all in that area. Crisis is an interesting area as well because the cost of marketing, the cost of advertising can largely be outsourced. Grants for that kind of work, if you are promoting a crisis program, really makes a lot of sense to foundations and state governments in terms of allowing you some coverage so that people know your number and know how to reach you. And crisis becomes a very valuable asset as we move into the VBR world, because what we're going to see is that it becomes that deflection that prevents folks from the emergency room and it prevents long-term stays in the hospital and thereby contributes to at least 2 of the big 5 metrics that we tend to see in crisis work. So what is crisis exactly, and what is a crisis program? When I got into it, I stopped after I found the first 15 names, and there are all kinds of crisis programs. There's no way to describe them except varied and unique. You can put together small to large crisis programs. You can build them in multiple ways. As I've noted, they can be site-based or mobile. They can be team or individual. They can be face-to-face or virtual. They can be residential or short visit. They can be population-specific, like some homeless programs or jail diversion. They can even be population-specific with respect to nursing homes and the aging populations. They can be group or individual focused in terms of the ways they're developed. You can link them with hospital systems directly by potentially placing staff in their ER or developing programs so that you can share records on folks and move back and forth efficiently, or they can simply be community-based. You can build it around professionals, you can build it around peers. Frankly, you can build it with both. And crisis programs work just as well for behavioral health or IDD. While many of you probably approach this with the idea that in my region, crisis programs are really dictated by the county or state, and it's limited to one provider and one purpose. Now is the time to think about expanding that by building some kind of unique offering that can be used in a crisis program that will provide a different and more a result that may be valuable during this pandemic. In terms of that process, I think there are opportunities and there are people at the governmental and the MCON who would be willing to listen to more than one authorized crisis program per region and might be wanting to look at unique alternatives in that regard. This is a place to brand yourself, to make a name for yourself. At the same time, you're building a strong referral base that will build into your programs and increase your productivity. I think this is a great time for outreach. I think this is a great time for the warm line. The program that simply announces to schools or announces to nursing homes or healthcare providers that you're open a certain number of hours a day to talk to them about their responsibility. After all, when you look at the mission that we live and we perform, it is our responsibility to have community support and prevention. And never has that been more essential than it is today, because everyone of every age from 3 up is stressed, anxious, and fearful about the future, and all of those are having substantial traumatic impacts on our communities. Suddenly, we have telephone and televideo connections that we've never used before and that we've never had access to before, and all of the regulatory pressures are being eased. We can use them in any way we want. It doesn't necessarily have to be used for the production of a fee-for-service unit. It can be used simply to get in touch with people and to make sure they understand that therapy, that case management, that other programs to support them, including hopefully as we reopen drop-in centers, will be available and that you have them there. Finally, I think that outreach intakes can be timely and effective. You can gather in substantial information on the phone in the first contact and ease the burden on the front desk staff, who will simply need to pick up a little more in addition at a later point. So using crisis as a tool to develop and increase productivity makes a great deal of sense, because people coming through that program develop positive and multiple referral sources within the system. And secondly, you do great community work and support your mission. And thirdly, you change the brand of your company and the way you're perceived because of the compassion and the way you've reached out through these warm lines. So I strongly urge all of you to consider the idea of working through your local papers and radios to let people know that you will have a manned warm line available for a period of time for parents who are having trouble, stressed with their children at home, for hospital workers who are seeing unbelievable things and living through enormous stress. You can tailor that to the needs of your community and the strengths of your program, but please consider this new approach to crisis as a way of increasing productivity as we look at maximizing our revenue. Finally, we need to talk about increasing rates. And this is the third key element before we move into discussions of the future. Increasing rates is always a difficult issue for us. We have been used to negotiating with people who are 10, 15, 20, 30 times our size, who represent governments, who represent massive insurance companies that are the size of governments. And when we look at what we, as a very fragmented, very diverse group of tiny providers actually have as we approach them, it often seems like we don't sit at the big boys' table when it comes to negotiation. I'd like to give you a couple background strategies on that you might want to use. A little bit from my old law school days in this, but nonetheless, I think just basic fundamental advice for the ways that you might want to increase work with these programs and increase discussions about rates. One, let's start by putting ourselves in the shoes of the insurer or the payer. Let's begin by finding out what it is that they do, who they are. Let's do the little bit of a development of a persona. The first thing I ask is, how do they survive? What's their source of nourishment? And what I look at is that governments generally at the county level and even divisions within the state, they live off of lump sum payments each year that are established by the legislature. their sole goal is maintaining expense control and not having to tell their political oversight that they overspent. So they are capped in the way they approach the world. MCOs that deal directly with governments receive a per capita payment. If there are 2 million Medicaid enrollees in a region or an element of the state, they receive a flat per member per month for each of those 2 million. And then they have to provide benefits within the limits of that coverage. Once again, their upside is capped. If you go see a foundation, what you're going to see in that regard is that they will operate generally by using the money that was paid in at some time in the past, and they look at the interest that's generated in the prior year, plus the donations, if any, and that caps the amount they're going to give out. Are we hearing a theme here? And the theme is capped, that people are at risk for costs over this total. There's no way to increase this total. And now we're dealing with a new group that I'm calling payviders. These are entities where their revenue is capped with the exception of value-based incentives, where they are combination insurers, providers, where insurers have purchased providers to deal with their structures. More and more, you're going to see insurance companies who are going to select large national therapy brands to work with as a structured level. So as you look at potentially negotiating with these 5, what you see right off the bat is none of them have any wiggle room. They might, during this crisis, be looking for extra payments from the state or extra money, or from their own bailout systems and so forth. They might be looking at other areas, but right now they are capped and they are in as much problem as before. Many of them, however, have an out they won't tell you about. And that out is that productivity that dropped, that cut your payments, also cut their budgeted expenses. Actual versus budget for them now leaves a substantial positive margin. You ought to know what that positive margin is for some of your key services, how far below budget you are, and you ought to use that as a target as you discuss with them how it is that you might increase rates even on a temporary basis, or particularly on a temporary basis, as we move forward. What are the pain points of these providers? All of them largely have the same 4. They are all subject to political pressures and problems of public relations. No one, with all of the angst and fear out there right now, wants to be seen in a negative light in a newspaper for any kind of activity that negatively affects people in the community who need it. And pressures in that regards about what you may or may not have to do about closing programs because of this problem or other structures, frankly, are going to be very valuable and are going to hit them at a place they understand. Secondly, all of them are scared to death about high-end utilizers. Whether it's during this crisis or not, they know there are certain people that are going to radically take up the vast majority of their budget, and they need providers who can address those people. And frankly, that's us. It is not the hospital systems. It's not the primary care doctor's offices. It is through the kinds of organizations, the complex care organizations that we run, that high-end providers are the best dealt with. So in that regard, we can create and leverage language with them in negotiations about the impact on high-end providers if programs close or if we need to move in new directions. Thirdly, to a much larger extent than you will realize, payers and providers are all part of the same cycle. I think of the yin and yang symbols that came from China, where the black and white elements swirled together in the center and are in fact all part of the single one. We rely on each other. Without providers or in the absence of sufficient networks to provide care, insurers and payers don't exist. Generally, if you meet with a payer provider, within the first 10 minutes of the conversation, someone will talk about partnership and use that word. And they're serious about it. It's what they feel and address, and it's another lever that can be used in your discussions with your payer systems. And finally, competition. MCOs and commercial insurances are operating very much on short-term contracts. The average insurer that would insure one of the local businesses or manufacturing sites in your area may only have a 2 or 3 year contract, so they're worried about someone who will do it better or gain some advantage with the payers that the providers they represent, and therefore be able to leverage it. State MCO contracts are usually 5 years or under, and as you look at that regard, the competition factor plays a big role. So these pain points become places that even in an environment where we understand their revenue is fixed, we can address and move ahead with conversations that will be impactful to their discussion. The next question we really have to ask is the product I'm offering really worth anything? And you have to look at that in terms of, does what I do reduce healthcare costs? Can I prove it? Do the people I serve value this? Are they engaged? Do I have a regional monopoly, or do I provide more of this in my region than anyone else, so that the loss of my services would seriously impact the reputation of the insurer who is telling folks he can provide everything? Finally, is it a low cost per unit service so that it could be expanded quickly and insurers could move? Generally, can you produce a unit for under $50 and kind of move in that regard? If we're looking at those questions, we have to look at what is it we want to raise the rate on and what will have the most impact to them. But I think this is an area for innovation as well. So I added a second series of questions. First, I want to know what is being done elsewhere? What might be done that would give me contract leverage in terms of innovation? Most of these insurers and the MCOs operate over very large regions, and they have pilots in a lot of areas. And they want to find services that work, and they may have ideas in that regard for doing things differently. Will this new service that I'm envisioning engage people in a new way? Can I make it scalable in ways that that might allow me to use it for more than one population? Many of us have skill sets we don't appreciate in that regard because we are also bound by specific regulations tied to specific parties. But the skill sets we have in residential are largely the same skill sets that serve the agent community in multiple ways, are largely the same skill sets that can be done for brain trauma patients and for other individuals. So as we look across the board at this, we have to ask that. The single question that appears in both categories, will it reduce my healthcare costs? Insurers are going to be looking for that in the long haul, and even though right now the reductions in the number of people seeking service to them is creating some budget surpluses for them, they are looking at a future of enormous demand. They are looking at a future where trauma cases and those kinds of difficulties for folks are completely exaggerated, where social determinants become really rare and unique resources to have in the community. So in some regard, if you can convince them about the healthcare cost process, you can touch on their fear of the future, which is a very extensive need with a very limited number of providers who can deliver it. So in these processes, we're thinking first of how they're paid and where their budgets are right now, then what their pain points are, and finally what my product might bring to them, I think we can see how this might work in a way that individual negotiations with providers can happen and be effective. Please note that I use the word individual. There is no mandated rule that I know of that requires commercial insurances or MCOs to have the same cost across the board for all services. Or as if many like to do that, they'll create unique differences along the way. There is room for individual negotiation between provider and insurer that, because of our history, is somewhat an agency of the government, we may not really understand as we move into this new world. Leverage in negotiation comes from your strengths and effectiveness, the brand and the footprint that you provide in your community and your region, how much you monopolize critical services, and how much you understand the local issues that your individual insurer is facing, as well as the pain points that they generally understand in the marketplace. If I were to talk about a theme for negotiation, it would be don't win the short-term battle, win the long one. Even if you don't get as much, build relationships. They're going to use the word partner when they see you. Use the word partner back. Talk about how much you want to work with them, individual staff they have that you enjoy working with, but don't undersell yourself. Understand that what you do really provides more value than you have probably in conversation or in general cultural understanding seen. Everyone knows in this industry that when therapies close, when therapy programs close, ER visits go through the ceiling, and that hospitals lose money radically as a result of increases in Medicaid populations that had not been budgeted for. These things are important for us to understand as we begin, and feel confident as you move into that. If you can't cut deals on the short term, do so in the long term. Create ways that they can effectively work with you, potentially in the new area. Try in some ways to speak business. The business dialogue is all about data and all about impact and financials and numbers. Have 3 or 4 sets of those things you want to show. How many of their consumers do you see on an annual basis? What's your average score in terms of satisfaction? And suggest that maybe those people are very happy with you. And finally, don't make this too formal a conversation. Feel free to share creative thoughts, to brainstorm, to show them that you're in a trust level with this discussion that might not be otherwise. That, I think, creates the background for us to begin to look at how do we go to those surpluses, which they have as a result of our low productivity, and find ways to increase rates and draw it down. Those, I think, cover the 3 major elements of developing short-term revenue relief, which are: 1, make sure your internal system is operating as effectively, as efficiently, and as standardized as possible. Run it by the metrics, make sure that everyone understands the goals and that everyone's committed to the same thing, and keep an executive focus on those numbers on a monthly basis, including thank yous and congratulations or concerns and questions to make staff know that what they are doing matters. Secondly, the ability to increase productivity by finding new ways to draw people into the system, potentially in this day and age through some level of crisis service, which can be thrown together in any way or fashion, as long as it's not a billable service and can be used to attract folks into better services in our company. Third, dealing with the negotiations around those rates, which is something we've never done, but that every hospital system does on a regular basis. What I want to focus on for the last 2 minutes is a few additional thoughts, but the idea that right now we need to be looking at revenue models. We need to be looking to the future in value-based reimbursement. So even as we address the financial crises we face, even as we have all this, the time is really now to look at the reimbursement of the future and to build so that we will have systems in place when it arrives. These trends are going to be negatively impacting us. I see payments favoring hospital systems and regional systems in the future as a result of the publicity and press that hospital systems have received. Very, very well deserved. Their pressures are enormous, but when a legislator thinks about healthcare, they're going to think hospitals more than ever in terms of increasing payments. In fact, mental health spending might be reduced as the economic downturn makes some legislatures think more about balancing the budget than about applying money to where it is needed in our communities. The other elements, you know about the melting supply chain. Insurers are becoming providers, providers are becoming insurers. This whole supply chain begins to melt, and the roles of people become largely structured around providing all of those services. Walmart is using national centers of excellence and actually shipping employees to specific places where there are contracts to do certain kinds of expensive procedures, less expensive, at a very reduced rate over what they may see locally. So services have become nationalized. We don't have the knowledge, the provisional knowledge about how to do virtual health that many of our payers, many of the other national payers do. We don't understand what to do on a cancellation and how to move the therapist to a different place, how to handle on-call so that people can be given the opportunity to call in as needed. All of these things, and then the developments of all of these new structured relationships with insurers and payers really creates a problem for us. And if you look at zero-based negotiations, if you look at that first page in the discussion of the payers where everything was capped, everything was set at an annual rate, when you look at that, only value-based reimbursement wins. But in addition to that, because we are a low-cost provider and a hospital is a high-cost provider, any change in flow from the hospital to us saves the insurer money and makes us their natural allies. So not only are we in a game that can only be won with VBR, we are in a game where we are very strong with potential VBR improvement. One of the things you have to worry about when you do a VBR contract is your risk tolerance. One of the things I'm working on and have ready to begin to provide as a product, I'm going to be discussing it later this next month, is a financial assessment, which is a series of 14 or 15 graphs, which look at different financial aspects of the company, talk about your strengths and weaknesses, provide suggestions about how you might restructure or begin to focus in different ways. And one of them is that before we begin any kind of discussion with a value-based reimbursement provider, we're likely going to get into a relationship that is part fee-for-service plus an incentive. They're likely going to want to have us reduce our fee-for-service rate so that we only get more money at the end of the year if our incentive is strongly positive. And the board's going to want to know how much money can they risk. This is a graphic that we've developed that basically says, if you want to keep your program or your current asset ratios at an acceptable level in the industry, then what you can risk in this contract or in any group of contracts that you develop is no more than what you're seeing in that green category. And for this particular entity, that's 0. Adjusting that requirement down a little bit, providing still good comfort, but not so much, not as much as you would like to have in a good, thriving business, you can move up to potentially $600,000. And if you're willing to go to the level where You might put yourself in a budget that if it were fully lost, you could end up hurting yourself in the future year or reductions in programming. This entity can do almost $19.5 million. Developing this kind of analysis lets the board pick their rate and allows you some guidelines as you move into value-based contracts to how you might do your green and your yellow and your red calculations to contract negotiation and to development of what you think your downside risk might be. VBR is not the end-all and be-all of the world. One, you can't completely affect all of the measures out there, so it inappropriately makes you accountable for things you don't control. You can talk about patients seeing a primary care physician, but if he decides to go on vacation for a month, there goes your reimbursement. People with complex care have higher risks. There are going to be increased technology costs. As a result of this reduced rate plus incentive at the end of the year, your benchmark year is going to have significant cash flow problems. Actionable information is often in the hands of the payer alone, and you frankly are not always advised of everything that's happening with respect to the patient. So there are dangers in VBR you need to deal with. These are not a reason to avoid it. These are a reason to get into discussions at very small levels at the beginning so that we can begin to learn them. VBR is not a way today to improve significant cash flow in the short term. It is a long-term solution for where we are, and I think in terms of that, it is a very positive outcome for this industry as a whole. We will be much more happy 5 years down the road as a result of this. However, there's a lot of work to be done, and it needs to be done now. Finally, I'd just like to hit some final thoughts. One is, you've got to ask yourself, who are you carrying within your organization? What programs do well and what programs do poorly? We've always in the past talked about ways where profits from one can support another, but is that really the case anymore? Many of our top profit groups have begun to fail, and many of the ones who have been losing money are dropping. This is also a graphic from my financial assessment report, and it basically shows the 5 programs that this provider provides, and it marks them in terms of profit and growth. And as you can see, on the crisis side, the crisis stabilization, that square on the top to your right is high profit, high growth. These are services that you want to strongly invest in. And the size of the bubble in this graphic actually shows you the size of the program, which for this organization is a little worrisome because, like so many others, it has residential services that are not growing in size at all, not getting bigger, and are also losing money, and frankly are consuming a very large portion of the share of the load. A graphic like this, I think, explained and talked through, allows people to look at their individual program and determine what they need. You can talk to your partial folks who are making a profit but not growing in size. Since they're making a profit, let's talk about marketing and outreach and let's build it. Your ACT team is very close to the border here in terms of profit, but is growing very fast, which generally means efficiencies of scale will come into place. So there's a place for investment. Maximizing revenue, if that's what we need to do in this day and age, for this provider generally means making some decisions about providing funds to those winning organizations and winning programs at the expense of paring back or shaving off a bit from the residential service. If an item falls in that category where residential is in this graphic, it really needs to be either a good source of referrals to other programs, an essential community asset, but frankly, why don't you take this graphic and go talk to the payer for residential? Show them the size and cost of this program and why rates in this area need to be increased. The last item I want to talk about is we've all talked about mergers and leverage and size. Frankly, as we're looking at that, I think one of the underused resources is independent provider association, contract agreements between multiple small providers who agreed to write contracts jointly, to negotiate together as a group and use their joint leverage to increase the rates that they receive. IPAs are exempt if the legal paperwork is done correctly from antitrust violations. Although there's a provision that requires that anyone can walk from the agreement whenever they want. Folks who are not ready for a merger and who don't have the time that a merger might take could be well benefited by the idea of quickly creating one of these so that they could begin negotiations on their own. In the true open minds fashion, let me close with a quote from Abraham Lincoln, that the best way to predict your future is to create it. One of the things that's most important right now is to be proactive. It is much better to be in process on an imperfect goal than to be stalled waiting to create a perfect one. And I think in that regard, we just need to have the confidence to take the first steps and to move into these directions for maximizing. My email is listed there. I truthfully would enjoy hearing from each of you any questions you might have or any ideas for additional work or effort that we might provide in assistance. Mina, that's what I have. Are there questions you'd like me to respond to?
Ray, yes, thank you very much. That was a very, very comprehensive look, and you covered all the bases, lots of great information in there. Albert has two questions. I'm going to give them to you one at a time. So a billing question first. What happens if the provider organization is billing one amount, but the insurance company is paying much lower than what has been billed? A lot of the time, we don't even know what insurance is actually going to reimburse.
That is a very, very common situation. The contractual allowance process is alive and well in all of healthcare, and I'm sure that all of us see it. The truth of the issue is that your payer system, your technology system must be able to give you the net billing at the time the bill goes out the door. You ought to be able to see and record in the month of that service what you really expect to collect and not the true value of the rate. When you negotiate, you have to negotiate around those allowances. But the fact that they are paying a discount is, to me, an additional feature that you want to point out to them, that they aren't paying full rate, that because of their size and volume, they've been paying at this discount. And that becomes a way to increase that amount. It is clear, though, that those two pieces are integral to moving forward. First, a technology system that tells you the net amount you will be paid in your revenue, in your income statement at the time of billing. And secondly, the ability to understand that that difference between the two is a range that you can begin to use with negotiating increased rates.
Great. Thank you, Ray. And one other question. What do you think is the future of inpatient residential treatment centers for adolescents? Do you think this business model will still be good after the crisis? What are the long-term prospects? And this is from a for-profit organization.
I love talking strategy, so I'm enjoying the question a great deal. Thank you very much for asking. I think that there is a place for a strong residential provider to build the programs of the future. There are states who are allocating money for supportive and predictive and monitoring technologies that move into these locations. Right now, your biggest cost in those residential inpatient settings is largely around staffing and meeting regulation. If those staffing regulations could be loosened safely, by bringing in the artificial intelligence, the telehealth, the other aspects of supportive care, then you might be able to staff in a different way. And even before this crisis, there were 2 or 3 states in the country that were beginning to explore that. For example, we need to know when medications were taken and that they were taken correctly, not just because a nurse gave them out, but in some cases because the person took it themselves. That may change the need for having a person in a intensive residential setting versus in a home setting. If we could move people in that regard with medications that simply reported back to us automatically that they'd been taken, pill boxes that were reporting that they'd been opened, those kind of monitoring structures, we could radically change the cost of that service. The second item in that is an amazing piece of work I saw when I was in Massachusetts. There are some fascinating folks there doing amazing work in a residential setting with artificial intelligence. We live, I guess, in patterns. We get up at roughly the same time, we do the same things, we move at roughly the same rates. An artificial intelligence monitoring system that can see those things actually has the capability to define our baseline and to begin to report when there are issues. Folks there in the software industry truthfully believe and have systems in place where it is working, that they can predict crises and difficulties with persons in intensive behavioral health programs long before they are actually visible to staff. I don't know how that works. It all sounds very wild to me, but I think there is a future in supportive technology in that site that reduces the cost of the service, that limits that service to persons of more intense need and moves other folks into supported residential settings in the community. I think that there is a future for that service because there's always going to be that need. But to stay part of that future, we're going to have to do some technology investment, and we're going to have to think of diversion opportunities that we would build around that so that we could use that kind of service only for the most significantly in need. And frankly, that who is most significantly in need will vary radically from today to what we might perceive in the future with a person fully supported by the technology around them.
Great, thanks, Ray. Are you aware that in some states, I believe this is New York, they are not allowing providers to collect co-pays on telehealth? Obviously, that impacts revenue. Do you have any suggestions around that?
Yes, public shaming, and I'm totally serious. I'm aware that there are, I believe, 3 or 4 states where that is the case, where that is not a federal mandate, and many states have opened it up and created those kinds of pathways in hopes of serving more people. And frankly, I think that would be a great question for Governor Cuomo's press conference, and it would certainly be something that you would want to raise with everyone and anyone you can find, because frankly, there's no logic to it. It's only that logic that used to exist, bureaucratic regulatory structure that said we have to limit the total number of services. In the trauma we face right now, limiting the total number of services has nothing to do with doing our mission. So please be aggressive and attack that. Most states, the vast majority of the states, are not with them, are opposed to them in the way they are trying to deal with you.
Thank you, Ray. Call for advocacy here. Okay, I'm not seeing any more questions come in. Last call for attendees. If you have a question, please chat it in. Ray will be around to answer. Otherwise, we will make the recording available to you, and you can follow up afterwards.
Mina, thank you so much for hosting this and for guiding me through all the technology and making sure that it all worked. Again, to everyone who attended, thank you so much. I hope it was meaningful. Feel free to reach out to me at rwolfe@openminds.com, and I would be glad to answer questions offline.
Great, thank you, Ray. And let me add my thanks to all of you. We also have our next web briefing in this series is on May 14th. It's at 1 p.m. Eastern, and we'll be talking about aggressive short-term business development, sort of building upon what Ray presented today. So one of our colleagues, Paul Duck, will be presenting. We hope you will register, and we will see you on that web briefing. Thank you all, and enjoy the rest of your day.
Thanks, everyone. Bye-bye.